Okay, so let's start with what is immunity part one. Our exemplar is sepsis, and that's found in your book at 9.f. So we're going to do a little bit of sepsis here, and then really we'll spend more time talking about it again, and as it leads into septic shock, because people can come in with an infection. They show up in the ED. I don't feel well. I got sick 2 hours ago. They're septic and in septic shock within a couple of hours. So um, we'll talk briefly about sepsis, and then we're going to do it again when we talk about septic shock. So be sure and have your outline out where you can follow along and take some notes. So let's talk about what sepsis is. Sepsis is an infection that has caused an exaggerated immune response because of that microorganism. It that immune response just overwhelms the body and it triggers widespread vasodilation. Okay, so our blood vessels get big. We have a decreased SVR, systemic vascular resistance, or a decreased afterload, and that can certainly lead to poor perfusion. So sepsis, the infections that lead to sepsis usually start in other areas, because sepsis means I have an infection in my bloodstream. They start in other areas. The two most common places for those infections are lungs and urinary tract, also called urosepsis. And so that infection and response moves from those localized places into the bloodstream. So the old term for sepsis was actually bacteremia. So you may still hear that. Now, it can originally start in the bloodstream with something like a central line infection, an infection of a pacer wire, ICD wire, IV drug users, IV catheters, all of those can start that. Certainly can be that wound on your leg that's got green pus coming out of it. It can start there. This infection is either bacterial, virus, or fungi, all of those. So it starts locally and it spreads throughout to the bloodstream. The other common sites that we can see can be GI. Female reproductive is important when we think about our lifespan and our pregnant women. So by definition, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. That's the definition. So let's talk about who's at risk. So certainly people who are hospitalized because you have invasive devices, so central lines, Foley catheters, which is why we have our Claudie and our CLAPSI bundles that we need to follow. Certainly people with chronic illnesses like diabetes, heart failure, or chronic kidney disease. Anybody has poor nutrition, malnutrition. Sometimes you'll see that PKM, protein calorie malnutrition. Certainly invasive procedures at risk for sepsis. If you're immunosuppressed, if you have wounds, and then age, the very young and the very old are more susceptible, especially the young because they have immature immune systems, and the old because they have lots of comorbidities. So clinical manifestations, signs of an infection. So think about which labs you're going to look at. You're going to look at your white count. That's going to be high. You're also going to look at segs and bands. Segs are your seniors. Bands are your babies. So your segs will be high because those seniors have been sent out to take care of that infection. As they die off from fighting that infection, your bands, your babies, that number will increase and they get sent out to fight the infection because it overwhelms your system. You're going to see tachycardia and tachypnea. Those are this compensatory mechanisms for poor perfusion. Change in LOC. You're going to have that widespread vasodilation. Initially, when we think about hemodynamics and what goes on, because of the tachycardia, our cardiac output will actually increase because the compensatory mechanisms are working. And so sometimes people call that warm shock versus cold shock. I'm not a fan, but it makes sense. As sepsis progresses and as it leads to septic shock, we will start to lose cardiac output and have poor perfusion. And if we're not doing hemodynamic monitoring, we're going to see low blood pressures. They're going to have positive blood cultures, and like I said, they can have change in LOC. So pharmacology, this makes sense. They need broad spectrum antibiotics. So vancomycin, Zosyn are the two most common. If we're going to start an antibiotic, we need to get our cultures first. So we need blood cultures, urine cultures, sputum cultures, the culture of that wound, whatever cultures we need. We always get our cultures first, followed by our broad spectrum antibiotics. We're going to give them fluid, normal saline or LR, so that is the standard. And if we need to and shock occurs, we're going to start vasopressors. So we will speak more to that in our shock lecture, which is the one to follow this one. Collaboration, certainly our healthcare providers, we may need to call infectious disease in. Respiratory therapies, if they starts with pneumonia, because these patients do end up intubated. Pharmacy, because we're going to be on lots of antibiotics. We may need our social worker, case managers, dietitians, spiritual care, because sepsis does have a fairly significant mortality when people become septic. The other, talking about diagnostic tests, we can also look at our electrolytes, and they may do ABGs. And also looking at a lactate or a lactic acid. A normal lactic acid is 0 to 2. Critical values are greater than 4. And a lactic acid tells us about tissue hypoperfusion. So it is a very common test. If you're getting a lactic acid on your patient, more than likely they are septic. And when lactic acid is produced, your patient will be in metabolic alkalosis. Now, what I want you to think about is when they come in and they're tachypnic, what is their acid-base imbalance, because they're tachypnic and breathing rapid. They will be in respiratory alkalosis, and then they switch to metabolic acidosis as we have tissue hypoperfusion and from the increase in lactic acid. So let's talk about treatment and recognizing these patients. And I have this in two different places. So to be septic, you have to meet Sears criteria, plus you have a suspected or confirmed infection. So we either know you have an infection or we suspect that you have an infection. So Sears criteria, you need 2 of these 4. Put a big star by this. This is important for you to know. So your temp can be less than 36 or greater than 38. So see why I asked you to learn 36 to 38. Your white count is less than 4, greater than 12. Why would somebody who has an infection have a white count less than 4? I'm giving you a minute to think about that. So there's 2 reasons. One is they're immunosuppressed, so they don't have a high white count to start with, or the fact that they have used up all their WBCs fighting this infection. Heart rate greater than 90, respiratory rate greater than 20, or a PaCO2 less than 32, and that's because they're tachypnic. So if I meet Sears criteria, plus I have a suspected or documented infection, you are septic. And we need to move to our 1-hour sepsis bundle. Now, a lot of people meet Sears criteria. I always like to say while I'm lecturing this and I'm walking around and talking, my heart rate's probably greater than 90 and my respiratory rate's greater than 20, but I don't have a documented or suspected infection. So this is vital that we recognize this, that if we get either a sepsis score or maybe a Mu score on our computers, that we pay attention, that it says, hey, your patient's meeting some defined criteria and we need to decide what this is. It's important to do this 1-hour sepsis bundle so that we can hopefully prevent them from going into septic shock. This sepsis bundle has been looked at several times over the course of the last probably 10 years for evidence-based practice. It is still the best that we have for evidence-based practice. They do say that if you are unsure that this is sepsis and that they are stable, you can wait a little longer than that first hour to initiate any of this, because we certainly don't want to give antibiotics to people who do not need them. But if they are acting septic, if they are starting to have poor perfusion, we need to do our 1 hour bundle. So what your 1 hour bundle is, this is in your notes, and you also have a little diagram of it. We need to measure a lactic acid. We need to attain our blood cultures. We need to administer broad spectrum antibiotics, and ideally we want to, or antimicrobials, because remember this could be viral or fungi. We want to do that ideally within the first hour of recognition. We want to do rapid fluid resuscitation, because what happens in sepsis is they have widespread vasodilation when they turn into septic shock. That is a distributive shock. So what happens is my vessel that is normal and full becomes twice as big, and my fluid volume is half as much. So the body is acting like it's hypovolemic when it's not. It's called relative hypovolemia. So the first thing we're going to do is give them 30 mils per kilo of fluid for hypotension, or if their lactic acid is 4 or higher. So for a 70-kilo person, that is right at 2 liters. So 30 mils per kilo. Now, some people are really concerned about heart failure patients, renal failure patients giving this kind of fluid. So evidence tells us that if the patients are well maintained with those diseases, they can tolerate this. Sometimes they order less than 30 mils per kilo, and they may give it over a longer period of time instead of a liter over an hour. What you need to remember is we need to fluid resuscitate them, follow your orders, and then assess and monitor that patient for signs of fluid volume overload, listening to lung sounds, because you're going to see it there first. We are going to use vasopressors if the patient is hypotensive, so a mean arterial less than 65, during or after fluid resuscitation to maintain that MAP of 65. So if during fluid resuscitation I'm not keeping their MAP at 65, we're going to add vasopressor. Norepinephrine is our drug of choice, or after fluid resuscitation. So that's important, because this is the point. When you add a vasopressor to somebody who's septic, they are in septic shock. That's just the definition of septic shock. I'm trying to make this easier for you. Okay, so let's talk about our lifestyle considerations. So infants, especially those less than 3 months, any temperature higher than 38 we need to be concerned with. We need to rule out sepsis. They do have that immature immune response. They're going to present with things like tachycardia, tachypnea, fever, warm extremities, bounding pulses, rapid cap refill, because, our cardiac outputs are up. We're working well because compensatory mechanisms are working. Their urine output's probably going to be normal. They might have an altered LOC. As shock progresses, we're going to have prolonged cap refill, weak pulses, change in mental status, decreased urine output, decreased blood pressure, and all of that happens in adults as well. And then infants will have temperature instability. So they could also have abdominal distension, poor feeding, lethargy, respiratory distress, hepatomegaly, vomiting, jaundice. Treatment is to identify this and give them antibiotics. So for our pregnant women, more common in those who are over 35, also for pregnant women who have comorbidities or invasive surgical procedures, so C-section. Tachycardia, increased WBCs, vasodilation. I like how your book talks about ominous signs of hypothermia, so they're cold and that's bad. Tachypnea and altered LOC, so really same thing, temp less than 36, greater than 38. Your book does talk specifically that fever is not an accurate indicator in women, so we do need to look at other things. But if you've got a trend, and specifically if it's going down, their temperature is less than 36, I would be concerned. We're going to treat them with antibiotics. So our older adults can have more problems because of aging, they do have decreased stroke volume, how much blood comes out per beat, and decreased cardiac output, which means their compensatory responses are not as good. They may present mainly with mental status changes like confusion, altered LOC. That could be their first sign that they have an infection. So we need to pay attention to that. And any of you who have worked in long-term care certainly knows that that happens. So there's your basic piece of sepsis. We'll add to that and really talk about septic shock in our shock lecture. Thanks.